Mr. Jameson, a 67-year-old male, presents with a history of coronary artery disease, type 2 diabetes, hypertension, and hyperlipidemia. He experiences crushing chest pain, shortness of breath, nausea, and diaphoresis. These symptoms suggest a potential cardiac event requiring immediate medical attention. Initial clinical findings reveal hypotension, tachycardia, tachypnea, and low oxygen saturation. ECG shows ST elevation in leads 2, 3, and AVF, indicating an inferior wall myocardial infarction. Emergent percutaneous coronary intervention, PCI, is performed to restore blood flow. Post-PCI, the patient develops oliguria with elevated BUN and creatinine levels, indicating acute kidney injury. This is likely due to hypotension and contrast nephropathy. Complications include hyperkalemia, fluid overload, and metabolic acidosis requiring careful management. Nursing priorities from is focus on continuous cardiac monitoring, frequent assessment of potassium levels and ECG changes, and monitoring intake and output. Evaluating for signs of fluid overload or the need for dialysis is crucial in managing the patient's condition. Medication management includes administering aspirin, nitroglycerin, morphine, beta blockers, and antiplatelets. ACE inhibitors require caution due to renal effects. Hyperkalemia is managed with insulin, dextrose, and calcium gluconate. Hydration protocols are critical pre- and post-contrast. Nurses monitor for neurologic changes, check arterial blood gases for metabolic acidosis, assess for pulmonary crackles and jugular vein distension, and adjust medication regimens based on renal function. These assessments are vital for patient safety and recovery. Tanner's clinical judgment model is applied, involving noticing, interpreting, responding, and reflecting. The nurse collaborates with the care team, reassesses labs and vital signs, and prioritizes interventions based on the evolving patient status, ensuring comprehensive care. A nurse reviews labs showing elevated creatinine and low urine output. The first action is to check the patient's potassium level, as hyperkalemia is life-threatening and must be assessed immediately in acute kidney injury, AKI. In a client with a myocardial infarction and AKI, a potassium level of 6.4 mEq is expected to show peaked T-waves on an ECG. Hyperkalemia causes these changes and may lead to arrhythmias, requiring prompt intervention. For a client with AKI prescribed enalapril, the priority assessment is the potassium level. ACE inhibitors can worsen hyperkalemia, especially in AKI, necessitating careful monitoring to prevent complications. Before a contrast CT, the most important pre-procedure action is to hydrate with IV fluids. This prevents contrast-induced nephropathy, protecting renal function and ensuring patient safety during the procedure. Post-PCI, the priority finding is a hematoma at the femoral site, which may indicate bleeding or pseudoaneurysm. This requires urgent attention to prevent further complications and ensure patient stability. A statement indicating a need for further teaching post-MI is "I can restart jogging next week." Strenuous activities should be avoided until cleared post-MI to prevent undue stress on the heart and ensure recovery. Bounding pulses indicate fluid overload in AKI. This, along with crackles and jugular vein distension, reflects fluid retention, requiring intervention to manage the patient's fluid status and prevent complications. An ABG reflecting metabolic acidosis in AKI shows a pH of 7.30 and HCO3 of 17. Low pH and bicarbonate confirm metabolic acidosis, necessitating appropriate treatment to correct the acid-base imbalance. Calcium gluconate is given in hyperkalemia to protect the heart from dysrhythmias. It stabilizes cardiac membranes, preventing fatal rhythms and ensuring cardiac stability during treatment. An increase in urine output from 10 to 35 mmol/H indicates AKI recovery. This early sign of renal recovery suggests improving kidney function, allowing for adjustments in patient management and care.